All right, good morning, everyone. It looks like most of our attendees have been able to join the webinar. We'd like to welcome you to our quarterly translational seminar related to cardiovascular disease. Today's topic is on computational modeling in TAVR. We have three great speakers lined up for you from the United States, Canada, and Australia today. We're thankful to be able to present this webinar to you in partnership with ViVitro. Kareem, did you want to say something briefly? Kareem, you're on mute.
Hello, everyone. Thank you very much for joining us from Americas, Europe, and Asia. ViVitro is very proud to support research at the Translational Lab at St. Paul in Vancouver and contribute to the advancements of in vitro testing in the cardiovascular space. I really hope you find our second webinar on computational modeling interesting and productive. Stephanie, thank you for hosting this session, and thank you for Dr. Hatoum, Ihdayhid, and Dr. Motamed for joining us. Enjoy the webinar.
Right, thank you so much. So for attendees, please know that the questions can be entered in the Q&A. And if you'd like to unmute yourself, we can make that happen as well. But the majority of questions will happen at the end, and there'll be a chance to ask a few brief questions between each speaker. So to kick things off today, I'm very happy to welcome Hoda Hatoum from Michigan Tech University. Had the great pleasure of working with Hoda throughout the years around computational modeling as it relates to TAVR and vascular health in general. Hoda, thank you for being here and sharing some of your recent work with us.
Okay, I'm going to share my screen. Hello, everyone. And thank you for attending this talk. Thank you, Stephanie, and the organizers for organizing this webinar series. Okay, here I am. I assume that everybody can see my screen. So I'm happy to be here to share some of our ongoing work on predicting leaflet thrombosis after aortic valve replacement. As Stephanie introduced, my name is Hoda Hatoum. I'm an assistant professor of biomedical engineering at Michigan Tech. And I added my information on this slide in case somebody has questions that we can't answer during this webinar, and my social media handles and my lab website in case you are interested to learn more about what we do. So I believe that this audience is no stranger to the problem of leaflet thrombosis. Leaflet thrombosis is an adverse effect that occurs after aortic valve replacement, whether it's transcatheter or surgical. And the incidence of leaflet thrombosis ranges from 0.3 to 35%. This is accounting for clinical, subclinical, surgical, and transcatheter. For TAVR specifically, I believe that the subclinical is about 35% and clinical is about 3-ish%. Leaflet thrombosis correlates with early valve degeneration, with thromboembolic events, and with heart failure, among other adverse outcomes as well. So considering that AVR is on the rise and the number of patients getting bioprosthetic valves is also on the rise, then we expect that leaflet thrombosis incidence is only going to be bigger and bigger, and we need something to address that. So currently, oral anticoagulation post-aortic valve replacement is the to-go way to mitigate leaflet thrombosis, but definitely it's associated with an increased bleeding risk and mortality risk. Some hospitals and medical institutions prescribe dual antiplatelets as opposed to oral anticoagulation. But for example, our collaborators at Mayo Clinic, they prescribe warfarin after transcatheter aortic valve replacement for up to 6 weeks. So it has been documented that once anticoagulation is discontinued, in some patients, leaflet thrombosis recurs. And currently, there are no available tools to assess the risk of leaflet thrombosis after aortic valve replacement, which brings us to the objective of this work, which is to develop a decision-making tool for cardiologists to determine the risk of leaflet thrombosis before aortic valve replacement. So basically, we want this tool to be integrated in the pipeline of pre-procedural planning so we can help cardiologists select the valve that works best for a specific patient in a way to mitigate the risk of leaflet thrombosis down the line. And this will be done considering patient baseline characteristics, the anatomical characteristics of the patient and the hemodynamic factors that are obtained from routine echocardiography. And this work is in collaboration with Dr. Derestani, who's an assistant professor of civil engineering at Michigan Tech, and he's the one who developed the model. So I believe that Yusuf will join us a little bit late because he has a class right before this webinar, but he will be the one to answer any specific question about the modeling aspect of this work. And also Dr. Mohammed Al-Khouli, who is a professor of medicine at Mayo Clinic in Rochester, Minnesota. So for our methods, we asked our collaborators at Mayo to basically select 100 random patients from their database within a 1-year time, and within 1 year to minimize bias and to minimize the different valve generations, basically. So a previous version of this work included 50-50, include a cohort of patients with 50% of whom developed leaflet thrombosis and 50 did not. And that was an early version of our work, but we realized that we ended up with likelihoods that were not really what is reflected in what is seen clinically. So this is a newer version of our work where we just asked Mayo to give us 100 patients who underwent TAVR and SAVR, randomly selected, hoping that some of them had leaflet thrombosis, and we were lucky. So one of them did not have good imaging data, so that's why we ended up with 99. And among these 99 patients, 3 had leaflet thrombosis, and 96 did not have leaflet thrombosis. And for each of these patients, we had access to their CT scans and to the echo that were taken within a very short time from each other to be consistent. And we extracted the anatomical data from the CT scans and the hemodynamic data from the echo. And we included all the data from echo that is routine, common for all the patients. And this is what we call continuous data as opposed to categorical data, which, for example, means diabetes, hypertension, and anything that is not basically continuous. So we used logistic regression, and I'm going to talk a little bit more about this as a first step to generate our prior model. And then we updated our model based using Bayesian inference. So we developed a mathematical model to take into account, for example, valve type, and also the categorical variables that include patient data, such as history of hypertension, diabetes, smoking, anything really. That is relevant to the patient. And ultimately, what we are after is to develop a phone app and a website that is like the STS score, for example, or the CHUV score, where it can be implemented within the pipeline so that clinicians can actively use it. But this is definitely not going to be done based on 99 patients, but we are collaborating with a few medical centers from the United States and from outside the United States to get at least 10,000 patient data. So we can build this database, update it continuously, and make this a live website or a phone application, which I'm going to address in the next few slides as well. So some of the anatomical parameters that we extracted from CT include the SCJ height, area, annulus area, the coronary heights, the characteristics of the sinus, for example, the height and width. This is what we refer to as height and width in the sinus. For the hemodynamic parameters, we extracted them from echo. As I mentioned, just routine echo. They include ejection time, ejection fraction, valve mean pressure gradient, among other factors as well. And the first step we did was to develop the logistic regression, which is a very simple, probably the most and simplest classification methods there is. And the reason is that we want a clear formula, mathematical formula that can be coded very easily in order to develop the model and to use it, as opposed to more fancy techniques. So, and the advantage of logistic regression too is that it gives us a probability. And we are interested in probabilities because we want to see which valve would suit a patient better. And I have a visual that would elucidate this idea a little bit better down the line in the next few slides. And in addition to that, we are interested in logistic regression because it also gives us the p-values so that we can eliminate the factors that do not contribute to the outcomes. So for example, if some anatomical variables are not significant when it comes to leaflet thrombosis, then we just eliminate them from our assessment. So based on our 99 patients, logistic regression gave us that the annulus area, the annulus to left coronary artery height, and the annulus to right coronary height were the most significant factors. Everything else turned out not to be significant. But again, this is only based on these 99 patients that we have, which is not a big enough cohort to extrapolate these findings and to make them general. So after we built the prior model, which is only based on logistic regression, we updated it using a Bayesian inference model. And the categorical variable that we selected was the valve type. And the most prevalent valve types in our 99 patient were the SAPIEN 3 and the SAPIEN 3 Ultra. So we chose them. We had about 5 patients with self-expanding valves and maybe around 6 or 7 patients with surgical valve, but the remaining patients were divided between SAPIEN 3 and SAPIEN 3 Ultra. So we chose the valve type to be our first step towards the update. And we also are plotting our results as a function of annulus area for the time being, just because it was the most significant, but the same can be done on the others as well. So these are our results. What you're seeing here is the probability of leaflet thrombosis versus the annulus area. And the black curve is without having Bayesian updating. So it's just based on the logistic regression. And once we updated the model based on SAPIEN 3, we ended up with this set of probabilities. And when we updated the model based on SAPIEN 3 Ultra, the red curve represents the one based on SAPIEN 3 Ultra represents the one with the Bayesian updating. So if we want to take an example, for example, an annulus area of 5, we have the probability of leaflet thrombosis using with the SAPIEN 3 Ultra is about 2.2%, and the one with the SAPIEN 3 is 3.8%. So it seems that the SAPIEN 3 Ultra, with whatever improvements Edwards have done on it, is associated with a lower risk of leaflet thrombosis compared to SAPIEN 3 for that particular annulus size, for example. So this is basically what we want to achieve, and a clearer picture is coming in 2 slides. So when we tested our area under the curve, it was 73% based on the testing data that we obtained, which is not too high. It's not like a very fancy result, but again, it's only based on 99 patients only. Actually, we divided our set in a way that 89 were used for training and 10 were used for testing. So given these very low numbers, 73% seems to be a promising first step towards getting a higher AUC and hopefully improving the model. And this is the big picture that I wanted to share with you. So we really want to have this phone app integrated within the pipeline. And this is how we envision it to be, similar to the Valve-in-Valve app. So for those who are not familiar, but I guess this audience is for the valve-in-valve procedures. If we have a failed degenerated surgical valve and we want to know what is the correct or the suitable size and type of transcatheter valve that can be implanted, we use this valve-in-valve app so that it gives us the options that we have. And similar to the concept of the valve-in-valve app, we want to translate our work into an application that can be integrated. So in collaboration with the Institute of Computing and Cyber Systems here at Michigan Tech, we aim to develop this phone app. So the first screen will be similar to the STS score, where clinicians will be able to check, for example, age, sex, race, history of coronary disease, of stroke, of whatever. And then they hit submit along with the anatomical data and the echo data. They hit submit, and this is what they see. So they have a list of available devices that are currently used. And I'm showing here just examples, and these numbers are not based on any calculation. They're just here for show. So for example, if a patient is eligible to have either Medtronic Evolute FX or Edwards SAPIEN 3 Ultra, for example, based on this example, the Medtronic Evolute has an 8% risk of leaflet thrombosis versus SAPIEN 3 Ultra, which is 11%. So it seems that for this patient, it's better to go with the Medtronic Evolute FX, for instance. So that is the aim, the overarching aim that we plan to achieve from this work. So in conclusion, there is a need to develop a tool to assist cardiologists with pre-procedural planning and to also help them with management of with patients after the AVR is done. And also we want to optimize the therapy that patients get so that they don't end up with unwanted adverse outcomes after a procedure that did not intend to have them get this adverse outcomes. And again, this study is only based on 99 patients from one single medical institution, but we aim to include from multi-centers, from different patients from multiple different years, a lot more patient data. And I guess our aim was just to show you that this is the road that we're taking, and this is the overarching aim that we want to achieve. So I really hope that you're excited about this work like we are. And at the end, I would like to acknowledge my lab and our collaborators at Mayo, and I'm happy to take any questions. Thank you.
Great. Thank you so much, Hoda. That's really exciting. I think it's great to show us how you begin your initial study and then incorporating large populations now and into a tool that can be used. Just reminding to the audience that you can enter questions in Q&A and we'll address them at the end of the webinar as one group. Maybe I'll ask you one quick question, Hoda, related to I saw you included
Stephanie, I can't hear you. You're breaking.
There. Do you this able to help decision between surgical and TAVR valves as well?
Stephanie, I did not catch the part before. Will it help make a distinction between surgical and transcatheter? I didn't catch that. Sorry.
Okay, I think we lost Stephanie. I think the question was, whether you could use that app, in the future to decide whether a patient would be best suited for a surgical or a transcatheter approach, because now that we are sometimes the decision is sometimes difficult between selecting transcatheter or surgical approach. So do you think that could be also used for that in the future?
That can be, although to be honest, we just wanted it to be a supplement to the clinical decision-making process, not to substitute it. I know that some patients, for example, might be for example, younger, so maybe a transcatheter valve is not really suitable for them. Some other patients have some anatomical challenges that transcatheter valve might not be. But the decision of surgical versus transcatheter, I think, is this is step 2 after they decide that. But if a patient is suitable for surgical, then I bet anyone can, given the durability data and all that, probably surgical should be the one, unless they have some reservations about not using surgical valve, whether a patient preference or maybe just the clinician judgment.
Okay, Stephanie, I don't know if you're back, but I think we can move on to the next speaker. Are you back, Stephanie? Okay, so
sorry, can you guys hear me?
Yeah, we can now.
Great. Sorry, yeah, that was my point, Hoda. Thank you for answering that. So we'll move on to our second speaker, who is Abdul Ihdayhid, who joins us from Harry Perkins Institute and Fiona Stanley Hospital in Perth. Abdul is an interventional cardiologist and clinician scientist who works with a great lab team there. Today, Abdul will tell us about his work around computational modeling as it applies to understand coronary disease and TAVR, specifically related to fractional flow reserve derived from CT.
Thanks very much, Stephanie, and for the ViVitro team, and David for inviting me. So I'm going to talk a little bit about cardiac CT and FFRct and TAVI, but really to sort of build to that, I'm going to start off really by talking about the concept or where we're at with coronary artery disease in aortic stenosis in general. These are my disclosures. So, TAVR now, there's been multiple randomized clinical trials that have highlighted that, TAVR is well established in our clinical practice as being either equivalent or superior to surgical aortic valve replacement across the spectrum of surgical risk. And, what we're seeing now is that, increasingly for the vast majority of patients, the device choice that patients are getting is TAVR. And this is data that's come from the US that highlighting essentially, if you're above the age of 85, 65, nearly everybody in the US just about is getting a TAVR valve. And, surprisingly, good or bad, under the age of 65, up to 50% of patients have been treated with being treated with TAVR. And so, as we are increasingly treating younger patients, as the indications with TAVR are expanding, we're increasingly going to be treating younger and younger patients, and then therefore the implications of what to do with coronary disease will increase with time. We're going to see at TCT, late breakers that are going to tell us about asymptomatic severe AS and the treatment of TAVI. And in the next 2 to 3 years, we've got the moderate AS data that's going to come out. And as I said, increasingly the patient cohort that we're going to treat is younger. And so what we've learned with from registry and randomized data is that the prevalence of coronary artery disease in aortic stenosis is quite high. It ranges between 40 to 80%, and that really reflects the differences in age and comorbidities that exist between the different trials and the different cohorts of patients that we treat. There's often been a question about, well, what is the impact of coronary artery disease on outcomes? And it's been, and when we talk about outcomes, there's procedural outcomes, and then there's the longer term outcomes of what happens to the patients as you follow them up with time. And if we look at the second aspect to it, the data seems to suggest that the more complex or more extensive coronary artery disease you have, the higher the incidence of cardiovascular death or all-cause mortality. But does that necessarily mean that we should be treating all that coronary artery disease to mitigate that risk? And that's where it's really been unclear. And so revascularization of coronary disease in the TAVI population really, as I said, remains unclear. And there was a paper that came out last year. This was an ESC consensus statement that made a recommendation for pre-TAVI PCI if you had a greater than 70% lesion in the proximal segment or a left main lesion, especially if you were symptomatic or you had a recent ACS. However, the data that was available really in the sort of stratosphere to sort of make those guidelines was somewhat contradictory. We had the activation trial, which had a lot of limitations, but it was a randomized trial of patients and highlighted that really there was no benefit to revascularizing coronary artery disease prior to TAVI. And we actually saw a signal for harm with a potentially increased risk of bleeding. Certainly where I'm from in Australia, and I think to some of my colleagues in the UK, we take quite a pragmatic approach to coronary artery disease before TAVI. That this was the work that came out of the Cleveland Clinic, which highlighted that if you had severe coronary artery disease, that you could safely do the procedure and leave the coronary artery disease untreated. And there were low rates of unplanned revascularization, MI. But kind of that's sort of been a spanner's been thrown into the works, as some of you might be aware that 2 weeks ago at the ESC, there was a late-breaking trial, the Notion 3 trial, which in patients who were both asymptomatic and symptomatic, who had very high-grade lesions with greater than 90% stenosis or a functionally significant narrowing of an FFR less than 0.8, pre-TAVI PCI was associated with a reduction in a composite hard endpoint, which is mainly driven by myocardial infarction or unplanned revascularization. So at the moment, despite, you may argue, well, okay, coronary artery disease is common. It seems to impact outcomes, but it's really unclear why we would potentially need to treat it. And so there are other factors though at play, and Stephanie and David through this webinar series have had some fantastic talks over the years about transcatheter heart valve design, and there's no doubt an interaction between the valve and the coronaries. And so, we know that every valve is different. It has a different geometry, it has a different height of the sealing skirt. It has a slightly different, projection of how the commissural post looks like and where it sits in relation to the native anatomy. And all of that can impact the way and our ability as cardiologists to get back into the coronary arteries in the future. And so if I was to sort of give you by way of example, here's an evolute valve. We've got the sealing skirt, we've got a commissural post, Now, you can imagine that if you have a coronary artery by here, the X, that it comes out on the side, well, then that should be pretty easy to get back into. But if the coronary artery is below the ceiling skirt or right in front of a commissural post, that can be quite challenging. But that's not the full picture. And as you know, the understanding this interplay between the device and the anatomy and the coronaries is more than just about whether the commissure lies in front of the coronary. It's also about the relative dimensions of the valve in relation to the anatomy. You can be commissally misaligned, but have a lot of space, and you might get back into the coronaries. Likewise, you can be commissally misaligned, but actually and completely fill up the sinuses, and that might have some serious implications about your ability to get back into the coronaries. And that's becoming even more concept. And again, this webinar series has talked a lot about this concept of lifetime planning and valve and THV and the concept of the neoskirt. But very briefly, when we put a second valve into the original TAVI valve, the original leaflets get put into a fixed open position in general, and that creates essentially like a covered stent around the original valve frame, or we call it the neoskirt. And so you can imagine, again, now that this could potentially have implications for getting back into the coronaries. And this is a really nice CT example that highlights it. You can look at this example on the left. This is a sapien valve. If this patient had coronary artery disease, this would potentially be relatively easy to get into because the valve is simply not interacting with the coronaries. Whereas if we look at the example here, there's a valve in valve, there's an evolute and evolute, and the neoskirt here is very high. There's no space between the native anatomy or the STJ and the sinuses. And so to get a catheter into here would be close to impossible. And there would be really implications here about getting back into the coronaries. So why is this important? What am I trying to get at here is that although we don't have a rationale just yet for, you know, the rationale for PCI prior to TAVI is up for debate, that some form of understanding of the coronaries is important because it could influence the device type. It could even influence whether the patient should go for surgery up front rather than TAVI. And then it is actually a key part of that lifetime journey planning. This was actually really interesting data that came out a few years ago, highlighting that if you had an ST elevation myocardial infarction, or for those who are not doctors on the call, like a full-blown heart attack or a blocked artery, that actually your outcomes are significantly worse, that your door to balloon time, or the time that it takes for us to open the artery, is significantly longer, fourfold higher PCI failure rate. Now, I'm an interventional cardiologist, there's interventional cardiologists on the call. PCI failure in STEMI is very low. And so, you know, and finally, the death or the mortality that came in these patients was sort of tracking nearly what you would see in cardiogenic shock, which is some of the sickest patients that we treat. Overall highlighting that the likely hypothesis here was that the interaction of the frame with the coronaries made treatment of these patients quite important. So if a patient maybe doesn't have a severe blockage today, but if you're 65, you're thinking about what could happen to this patient over the next 25 to 30 years. If they develop a heart attack, what would be the implications of that interaction of that valve frame with their coronaries and their ability to treat the patient? So with that, then it leads to, well, you know, should we be assessing coronary artery disease in TAVR patients? And so for the vast majority of health jurisdictions, certainly here in Australia, I know that in Canada, in the US, and I know that appreciate my colleagues in the UK maybe take a more pragmatic approach. Some form of assessment of the coronaries before TAVI is routinely done. You know, patients get diagnosed with the disease, they see a clinician, they get a CT as part of the procedural planning, but an invasive coronary angiogram is invariably part of that patient journey. And so, you know, with an angiogram, we're looking for narrowing or blockages in an artery. And, you might argue, well, what is it about blockages that makes them, you know, important? For those who are not, you know, maybe don't come from a medical background, this is on the left here is seminal work done by Lance Gould in an animal, which has subsequently now been validated in humans recently in a letter to NEJM, highlighting that really there's, you know, as you're, after about a stenosis of around 50%, you get a significant drop off in coronary flow or coronary perfusion. Now, that really formed the basis for a lot of what we do in cardiology, that actually, if you have a significant narrowing, then, you know, then they should be fixed because you're impairing blood flow. But we've increasingly understood that actually what visually looks severe might not actually be severe by virtue of a reduction in blood flow. And so we needed a tool to be able to understand that relationship between the anatomy and blood flow. And that was where fractional flow reserve came, which measured the pressure distal to a stenosis versus its pressure proximal to it, and gave a relative reduction in that. And it's been validated that a cutoff less than 0.8 was well defined to define some form of ischemia. And people might debate whether that's the appropriate word. But it's a tool that we use in the cath lab to help us better define coronary anatomy and whether it needs treatment. And it's impacted physiologically by several things. So the stenosis itself, if the stenosis is really narrowed, the length of the lesion, if you have a really long narrowing, you have more pressure loss, more friction, frictional forces across that narrowing, and therefore you have a greater pressure drop. If you're supplying a really large myocardium, a really large part of the heart muscle, we know that the larger your heart muscle, the more blood flow, and therefore the more blood flow across a narrowing, the more pressure loss there will be across it. And so they're all the factors that are involved, in addition to having an intact microvasculature. And so, this is important because in aortic stenosis, there are changes to the coronary physiology. By virtue of having a narrowed heart valve or aortic valve, the heart has to work harder to pump blood around the body. And so one of the primary pathological mechanisms is that the left ventricle hypertrophies. And that hypertrophy of the left ventricle impacts the microvasculature or the function of the small capillaries in the heart muscle and can blunt the vasodilatory response that we need for FFR. And so what we see with fractional flow reserve in the setting of aortic stenosis, that we get falsely negative FFR, i.e. the value is not as low as we would anticipate it to be. And there's been studies that have highlighted that if you did an FFR prior to fixing the aortic valve, and then you repeated it afterwards, that there is a change of around 0.02, i.e. that the FFR drops even further once you relieve the stenosis, because the microvasculature starts to become healthier again and can better respond to vasodilatation. So in our clinical practice, typically, if you therefore have an FFR less than 0.8 with aortic stenosis, it typically means that there's that significant. And if it's clearly above 0.85, it's probably fine. But if it's sort of close to the cutoff, that maybe if you repeat it again after TAVI, there may be other implications. So what about CT? Now, CT is become the gold standard for the way that we assess coronary artery disease. And it helps us rule out disease, identify stenosis severity, and also identifies plaque that we can use to guide medical therapy. And increasingly now, there's been interest in how we change an anatomical test also into a functional test that gives us the ability to determine FFR non-invasively. And, there's been now over 15 years of data now to support this, which high accuracy compared to invasive FFR. At an engineering level, you really need three key principles. You need a three-dimensional anatomical model or a geometry of the coronary arteries. We make assumptions about the physiological model of circulation with boundary conditions and the microcircular vascular resistance, and then we compute the coronary flow using the equations of fluid dynamics and supercomputers. And this is a more of a technical slide, which I'll skip. But all to say that the question then arises, well, okay, coronary artery disease, CT is a great test for coronary artery disease, but everyone's getting a CT in aortic stenosis, yet we're still doing an invasive angiogram. And why is that? And so we're doing a pre-TAVR cardiac CT, and we do that for procedural planning. It is CA is used to assess coronary anatomy, but for many, the reason why CT is not used in aortic stenosis is because of reluctance to optimize image quality, because of the safety concerns with giving GTN and beta blockers. And, there's been a lot of studies that have been done in CT without GTN and beta blockers, and it's shown that although the sensitivity is high, its specificity is not very good. And it's probably because of the high burden of disease, as I mentioned earlier, and the lack of optimizing the image quality, which impacts its accuracy. And what we've shown is that the GTN in general on cardiac CT definitely improves the accuracy. It's particularly the sensitivity and specificity. And so, one of the questions was, well, actually, the guidelines recommend that actually state that GTN is contraindicated in aortic stenosis, but there really isn't any evidence to support that. And you may argue, well, do you really need a trial to show that parachutes are needed when you jump out of a plane? But actually, there was one study that highlighted that GTN in decompensated aortic stenosis, i.e. a high-risk cohort of patients, actually demonstrated that you actually got benefit from having some form of GTN, even in extremis. So we decided, this is during my PhD, I worked with my colleague Michael McHale, who's now in the UK, and we did a pilot study in 42 patients. We gave them they all had clear-cut severe aortic stenosis. We all gave them beta blockers and GTN, and nobody died, and we didn't have any adverse events. And the GTN was well tolerated, and we did invasive FFR in all of them. We gave intracoronary GTN during the coronary, and we demonstrated that FFRct in aortic stenosis had high accuracy compared to CTCA, and highlighted its feasibility. And so we've decided now to extend that further, and this is a study that I've been doing along with my good colleagues, Professor Jonathan Leipzig and Dr. Stephanie Sellers, where we ran an international multi-center registry to expand this further. We gave patients who were having their routine pre-TAVR CT, we gave them nitrates and plus minus beta blockers. We looked at their coronary arteries, and did an 18-segment read. And if they had moderate disease, we did an FFRct to better risk stratify. And that data became part of the heart team discussion. And we decided whether to defer invasive angiography or not, and therefore to guide decision-making. And, we're planning to present these results at TCT and at TCT. But just to highlight a few examples, this is a 70-year-old male who had clear-cut severe aortic stenosis. We gave him 2 sprays of GTN, 25 milligrams of metoprolol, and a calcium score of nearly 2,000, that invariably this would be a non-invaluable CT using even modern non-photon counting technology. And we were able to really clearly see the entire coronary anatomy, and the FFRct provided another layer of confidence. And during the heart team, we were able to skip the invasive coronary angiogram and go straight to TAVI. And really just sort of highlighting that that as we're treating younger and younger patients, that although we might not want to revascularize every patient, but understanding their underlying coronary anatomy and their physiology may have implications into the decision on the type of valve and potentially the lifetime risk that this patient may have in the future. And so, I appreciate I'm getting short on time now, so I'll go to my final slide, where I think that the field is evolving to try and we're going to see an avalanche of patients of aortic stenosis. That is, it's only going to increase, and until there's medical therapy for the condition, device therapy is going to be the mainstay. And so we need more efficient ways for that patient journey to go from diagnosis to treatment. And certainly, if we can remove the invasive angiogram as part of the routine journey, particularly that the vast majority of patients don't get PCI, we think that there could be benefit to streamlining the process, reducing cost and complications, and reducing the door to valve time. And cardiac CT with FFRct has some promise in providing non-invasive planning and risk stratification. And we certainly look forward to sharing some of our results at TCT. So some of the take-home points would be that coronary artery disease and aortic stenosis is common. It's unclear, the evidence to support to routine PCI, although recent data may seem to support that. It's important to understand the interaction between the device and the anatomy, particularly for feasibility of coronary reaccess. CT in aortic stenosis has modest specificity, and that can be improved with GTN and rate control, and also FFRct. And optimizing the pre-TAVR CT has the opportunity to improve workflow and guide treatment decision-making. So thanks very much.
Thank you so much, Abdul. Really interesting work. We're really looking forward to see your presentation at TCT in a few weeks. I think we'll move on to our next speaker. Our next speaker is Dr. Zahra Motamed. She is joining us from McMaster University, where she's an associate professor in the Department of Medical Engineering, and she's going to talk to us about ventricular function in TAVR. Please go ahead.
Okay. Hello, everyone. Thank you very much for the invitation. So I don't know if you can see my slide.
Yes.
Okay, perfect. Okay, just a very brief explanation about premise. As probably all of us know, that hemodynamics and biomechanics play a critical role in both progression and initiation of the disease. But right now, for both diagnosis and prediction for intervention, so the clinics rely more on qualitative data, which is actually emerging the system symptoms rather than local and global hemodynamics. I mean, we believe that we should quantify them. So generally, the goals of my lab right now, we are developing non-invasive image-based computational framework, both for diagnosis and also prediction. And we are focusing on transcatheter heart valves, aortic stenosis, and also mitral valve diseases. So a critical note that many researchers in this field already demonstrated and acknowledged that valvular disease is a complex disease that depends on also ventricular disease and also vascular system. So I mean that we should think about upstream and downstream. So therefore, based on those demonstrations that we also were part of that since 2014, we believe that we should quantify not only the valves, but also ventricles and transcatheter heart valves. So when we are discussing about valves, I mean left side heart valves, both valves, aortic valve and mitral valve. So I will try to give some information briefly that why we meet that both valves. So first of all, I'm going to introduce you to a Doppler-based computational framework that we can quantify cardiac function. So it's fully Doppler-based. Briefly, this is a sketch from methodology that we need only few input parameters from Doppler echocardiography. So generally, they are measured reliably. So the code changed several times until the point that now we need only few measures from Doppler echocardiography, and all of them we can measure reliably. This is very important because not all of them it's reliable when we are dealing with Doppler echocardiography. So, and we can actually quantify metrics of hemodynamics, cardiac function. So this is one example of patient who received transcatheter valve TAVR, transcatheter valve replacement. And as you see, there are some information about workload, about left ventricular pressure, left atrium pressure. And as you know, those are the information that in clinics we can get them only through invasive cardiac catheterization. And also they are in part. So the information that we can provide using non-invasive algorithm that we have, it's really, really more than this. So more than the thing that catheter can provide. So I'm giving you some actually examples and argue some cases in TAVR that the patient actually was in a worse situation after TAVR. So as you see here, workload is reduced. So this is expectation that we have. So the patient underwent risky and pricey, intervention, and then because we predict that the situation should be better, and it seems that it's better if you look at maximum left ventricular pressure, for instance, and also the magnitude of workload. But there are some cases that the situation is not like this. So we publish actually several papers, I should say since 2014 in clinical journals. And in any population that we deal with them, usually between 15% to 25%, the situation was worse either, or it was so-so. So we put a criteria 5% better, 5% worse. So for sure, the patient didn't do that procedure just for improvement around 5%. So those are the cases for mixed valvular disease. We mean that, valvular disease and mitral valve disease altogether, but the patient only received transcatheter aortic valve replacement. And as you see, it's only for load, but some cases load increase. But the other point that is very important, that for all patients that we work so far, Doppler echocardiography pressure gradient universally reduced for all cases. This is actually the criteria that clinicians look at that. And if the valve opening and closing, in a good way, and also the Doppler echocardiography pressure gradient reduced, so for them is the key of the success, and surgery is successful. But for us, this is not the point, always. So and those are the cases that you see. I think they are around 72 cases with actually aortic stenosis and mitral disease that received TAVR, and then around 20%, 50%, again, based on population, the situation got worse or didn't change at all. So there is one more case that I wanted to case. Anything that you see here, they are actually real patients. None of them, they are hypothetical cases. And all cases we validated because we have also access to the actual case after TAVR, and we validated the situation either with catheter or Doppler sometimes with, with CT, in terms of quantity or quality. So this is another case that you see that post-TAVR load actually increase. The other thing that we are thinking that is important for transcatheter heart valve, that if we can predict the situation, but before intervention. So the second panel, we actually predicted, again, we validated, the situation and worked very well that the actual case, the patient has severe AS, mild to moderate AR, and moderate MR, but in reality, the patient only received TAVR. So if you look at the graph, so if the patient actually, just fixed aortic valve disease, which we assume that AR and AS will be corrected altogether, so around 48% we will have improvement for left ventricular workload. And if we are, fixing the mitral valve regurgitation, so 38%. In reality, that patient only received TAVR, but if you see the difference, we shouldn't ignore mitral valve. There are other cases that we documented in previous papers that sometimes even mitral valve has more critical role in terms of left ventricular, workload, but it was ignored, completely. So this is left ventricle function and hemodynamics, and this is also another slide that that we published that work, I think 2020, and it's around 40 patients that, as you see, universally for all patients, Doppler echocardiography reduced significantly, but this is not the case for left ventricular workload. So we should actually be cautious, and also we should also quantify. We believe that we should also quantify, cardiac function metrics. So we also investigated vertical flow, intraventricular, fluid dynamics precisely, not as much as we considered, for example, for left ventricular workload, because this is more intensive, but we also work on that significantly. And we realized even for intraventricular fluid dynamics, same population, 10%, 50%, situation got worse. So we checked actually, vortex metrics and also wall shear stress, different fluid dynamics, different indices that even clinicians, introduce, and we proved that this is a case that should be investigated. So one case that you see here, the patient has severe AS and receive actually TAVR, and because of changing of physiology and pathophysiology, changing the, forward stroke volume, a little bit paravalvular leakage or whatever. But if you look at mitral valve side, you will see that clearly and qualitatively, even it's obvious that mitral valve, wall shear stress also increased significantly. Other thing you will see in the other side, stagnation. That also we recently published, 2023 Structural Heart and American Heart Association. I believe they were around 35 patients that we received from Hamilton hospitals, and post-TAVR, as you see, everything looks better, in terms of opening and closing of aortic valve, in terms of reducing Doppler pressure gradient, and the things that clinicians look at that, but stagnation actually got worse, So this is actually about left ventricle, that when we are discussing about transcatheter heart valve, either aortic valve or mitral valve, so we should look at everything. So upstream and downstream, this is a complicated situation, and only looking at Doppler echocardiography, we believe this is actually underestimate the situation. So, I mean, discussing the premise that we have, that when we are saying quantifying heart, we should quantify valves, both valves, ventricle, and also vascular system as much as relevant. So we also developed a fully Doppler-based, frameworks that we can investigate stress and strain on leaflets, both on aortic valve and mitral valve, and all their, intervention. And I'm sure that you know that this is very important because of durability. When we are discussing about failure of prosthetic valve, this is very critical, and actually stress and strain is in charge, of that, and also for progression of calcification, that later I'm going also to share some information about calcification. So it's fully Doppler based. So the algorithm that I just discussed about cardiac function is fully Doppler based. my students develop actually a fully Doppler-based, finite element framework that we can reconstruct, the leaflets only with 2 images from Doppler echocardiography and 5 to 7 measure, measure from Doppler echocardiography. We can reconstruct the leaflets. And then boundary conditions, initial conditions, all of them came from the previous, algorithm that also this is fully Doppler-based. And we can, assess stress and strain on aortic valve. So these are 3 patients. I believe that those are the cases that we received from St. Paul Hospital, if I am right. I think, I'm not sure, but we also, did it, I think, on 12 patients, published the papers, and you can see actually different information there. They are only sample cases that we also reported, hemodynamics. You can see qualitatively that valve dynamics in some cases actually got worse after TAVR. Yes, I mean, it's opening and closing nicely after TAVR. It's not a stock like pre-TAVR that you can see that some cases a stock and one leaflet, couldn't open and close properly, but the quantification shows, other story. So here you can see clearly, if you look at the, pre-cases and post-cases, that post-cases, the situation got worse, in average. In some cases, they are better. In some cases, actually got worse. And this is patient-specific, finite element modeling that can assess stress and strain and other, solid mechanics parameter like material properties. We can also assess that one, and based on, each leaflet, that I think that this is very important. But just a message that for all, again, patients that you see here, a Doppler echocardiography pressure gradient reduce, significantly both mean and max. All valves opening and closing, closing perfectly, post-TAVR. But if you look at the data, the quantitative data actually showed other stuff. And so I wanted to emphasize all frameworks that I'm presenting right now, they have major validations, and they were documented, in actually those papers. For the sake of the time, unfortunately, I'm not sharing those information. So this is another, a slide exactly with the same patient that we also checked left ventricular workload, the same message that not all of them improved. Generally, most of them, they improve, but not all of them. As I said, around 50%, 10%, depends on population that we are working on that, but we see something like this. So exactly because of discussion that I had just few slides ago, that aortic valve and mitral valve, they have interaction with each other, and this is obvious. Cardiovascular system is mechanic. Disease, they are mechanics. Devices that they receive also, they are mechanics. So they have mechanical interaction, and easily they underestimate and overestimate the situation. So because of that, we believe, and we demonstrated through publications, that whenever that we are discussing about aortic valve, certainly we should check also mitral valve after intervention or any medication, any intervention of surgery that they receive. Same thing for mitral valve. We should check also aortic valve, and right now we are doing other kind of modeling on, on animals, and we see clearly that situation, that when we are checking actually mitral valve intervention, we should also check aortic valve, and inversely. So because of that, we developed another framework that is also fully Doppler-based, all of them done by my PhD students, that, and then the papers, they are right now under review. It's only for mitral valve, again, we just a little bit more sophisticated, but still we need Doppler echocardiography data only, with 4 images from Doppler echocardiography, and also few measurements, again, from Doppler echocardiography. We can reconstruct the leaflets, and everything is fully Doppler-based, all algorithms that they are coupled with each other. All of them, they are based on Doppler echocardiography. And this is actually one example of the framework that we can calculate stress and strain on mitral valve. And through our understanding, I think around 30-something patients we investigated so far, we again clearly see that stress and strain, like hemodynamics, have actually same story, that after TAVR, some mitral valve situation got worse. So we realized that in 2014, 2015, that in some cases, mitral valve got worse, after TAVR, and even there is no problem, but then after that, there are some minor maybe leakage or regurgitation. So, but using computational, patient-specific computational modeling, we can assess the situation, in details. The last part of my presentation is about calcification scoring. So calcification is promoted and progressed by mechanical stress and strain. And as you know, this is very important, can cause major complications, is important for clinicians. Depends on topography and this distribution that it has, the patient should or should not receive, transcatheter aortic valve replacement. We also developed CT-based framework. Again, my patients is not me for sure, and that actually we can, quantify calcification, pre-intervention and post-intervention. So the case that you see here is for tricuspid valve. In terms of geometry, any framework that we are developing for tricuspid is much easier, but also we extended the framework for bicuspid aortic valve that we can quantify calcification, pre-intervention and post-intervention. We have better understanding now about biomechanics of calcification, and that's all. So if I wanted to summarize, I mean, the things that we observed and demonstrated, and there are many actually clinical keys also from clinicians, in the literature, we really need to investigate, everything all together. So it's a very complicated situation. Looking only at Doppler echocardiography pressure gradient really doesn't help. And I mean, those are my wonderful students. I mean, without them, for sure, we couldn't reach to that point. And my, great clinical collaborators that we are working with them across the world. The last thing that when we are discussing about around 20% of the patient is just a magnitude in our mind that as a group, when we are working on different, for example, population, we see that around 15%, 20% doesn't work generally. Last year, I actually met one of my close collaborators, Dr. Josem Delato, and they said also they clearly see that around 20%, 25% of patients, TAVR doesn't work, because of different disease, because of different problems, some of them is short-term and long-term. So I think clinicians and engineers, I mean, they have no other choice. They should work together and then find a way to see it, comprehensively rather than looking only at the aortic valve, locally. But thank you very much for your time. Happy to answer any question if you have.
Thank you so much, Zahra. We greatly appreciate that. And thank you to all the speakers.